CataractCoach.com. Welcome to episode 10 of our podcast series. Today we have Dr. Fasika Woreta. She's the director of the ophthalmology residency program at the Wilmer Eye Institute of Johns Hopkins in Baltimore, Maryland, here in the USA. She's also an expert in ocular trauma, and she's done specific training in that regard and set up a beautiful ocular trauma center to really bring the highest level of care to these very complicated patients. We'll also talk in detail about ophthalmology residency and what's the future of it, what's the best way to learn, what are the challenges that are facing the young doctors in training today. It's about an hour long. There's some really great material. I think you'll really enjoy it. And even I picked up some great pearls about how to best deal with certain ocular traumas. And those are things we're all going to see. I hope you enjoy it. Check it out. So I want to welcome you guys to our Cataract Coach podcast. And today we have Fasika Woreta. She is the head of the residency program at the Wilmer Eye Institute at Johns Hopkins, professor there as well, big interest in not only cornea and cataract surgery, of course, but ocular trauma, including a fellowship, which is very unusual, at Moorfields in not only trauma, but also cataract trauma. So this is obviously, if you're a Cataract Coach fan, you know this is a great topic, and we love all this stuff. So welcome. Thank you so much for taking the time out to talk to us.
Thank you so much for having me, Uday. Great to be here.
Yeah, so the neat thing about you is I did my homework. I did my due diligence. So it looks like you grew up very close to where you practice now.
Yes, so, I am a Maryland native, and I went to undergrad at University of Maryland and stayed at medical school for Hopkins, Wilmer for residency, and I just left to do a fellowship at Bascom Palmer in Moorfields, and then I went back to Hopkins, where I've been ever since.
And you did an MPH too, so I like that as well. That as well. So one of the things I really want to talk to you about is, I was involved with resident teaching as well for a very long time. I did from the year 2000 to 2022, or 22 years worth with the residents at UCLA, and I had a fantastic time. But residency programs are changing a lot. And what are some of the changes that are happening now? I know some people may not realize, like me, that residencies are now just no more two matches. You don't have to do an internal medicine or rotational match for an internship plus an ophthalmology match. It's all together. Is that nationwide, and do you think that's a benefit to the programs?
Yeah, so for ophthalmology, it is nationwide. So every program starting, several years ago, and this was the final year where you would get a citation if you weren't integrated or joint, has integrated their internship. So they can either be integrated, where it's all under the SF match, and ophthalmology is the residency program director. So that's our situation at Hopkins, or it can be joint, where medicine is, or surgery, or whatever specialty you're associated with is the program director. But you just match at one institution for 4 years. So I think the main benefit of it is to get the interns exposure to ophthalmology for 3 months, as well as they get used to the institution. Well, they'll be out for the next 3 years, so they'll be integrated with the consult services, as well as the EMR that is used at the hospital. So it's definitely, we've seen great benefits. This is our second year. We're finishing our second year of integrated interns at Hopkins.
Yeah, so it's kind of nice. You get to not only hit the ground running. So when you're PGY2 and you're starting that first full year of ophthalmology, you've already been exposed to it. So you said about 3 months in the internship year would be ophthalmology, nine months of let's say rotating or medicine or surgery or something else. So the total now becomes 3 years and 3 months of just ophthalmology, so 39 months. Is that enough? And the reason I ask this now is I'm always surprised at how much our field advances. Like, I hate to admit it, when I finished residency in the year 2000, there was no OCT machine, there was no lamellar corneal transplantation, there was no anti-VEGF injections. It was just a different world. So our residents not only learn everything I learned, but like everything else that happened in the last 20 years in the same amount of time. Do you think it's enough time?
I actually do think it's enough time. Now, I think the integrated internship is really beneficial in giving that 3 months of extra ophthalmology to help with that transition to PGY2 year, because I think that's the hardest year for residents across the country. So they're doing a lot of emergency care. Their learning curve is so steep. It's nothing like what they learned in med school. And so I think that extra 3 months in intern year really helps them to get ready to take independent call. I remember when I was a resident, we had 2 weeks of buddy call, and then it was you in the ED. So that was a terrifying experience. So I think this 3 months plus, now we have 3 months of buddy call, even as a PGY too. So I think, the transition is definitely better than what it was when some of us trained. And I do think it's enough. Now, one interesting trend we're seeing in graduate medical education is a lot of talk about competency-based evaluation of milestones. So as we know, it's really not the numbers that necessarily matter, and everyone reaches competency at a different number. So for example, plastic surgery, they're piloting a competency-based time variable training, which I love that idea because like you said, it is enough for most residents, but there may be some who do need a little bit of extra time, and judging on competency versus numbers and a set number of years, I think moving towards a competency-based time variable training, I think is something that will be investigated in the future.
So what would be those milestones then for checking for competency, just for example? Because, most of our audience is not involved in U.S. academic ophthalmology, so it's kind of a new concept to them. I know I was with residents always having to do the milestone things and the evaluations, but what are some of the milestones?
So the ACGME has these milestones that we've been using for approximately 7 years now. Like when I was a resident, we didn't have the milestones, so we judged them on medical knowledge, professionalism, the 7 core competencies, and surgical training is under that. So as we evaluate them each year based on their milestones, making sure there's adequate progression. Like again, some people will reach it earlier than others. So you might think that for some people 4 years is enough, but again, for some people they may need an extra year. So I think the milestones help us evaluate and compare residents in the same class. So it's actually been quite helpful. And actually they have new milestones for faculty educators too, which I think will be helpful for evaluation of surgical teachers.
Oh, yes, you got to teach the teachers, right?
Absolutely.
You got to make sure the teachers are basically on the same page with the curriculum. Yeah, in fact, what you were saying, if I think back at the 22 years that I was with UCLA, there were some residents who needed an extra 6 months of residency, and there was one resident who needed an extra year. But again, the goal was, of course, to make that level of competency.
Absolutely. And as we know, too, some residents the surgery comes a little bit more naturally to some residents than others. So the other thing is you don't know that when you apply in ophthalmology. So I also think one thing which is a little bit controversial is thinking about like when, let's say a resident's a great resident, except they're not a good surgeon. So they're, considering alternate paths, like, for example, medical retina or neuro-ophthalmology, where we won't graduate them as surgeons, but in medical subspecialties is something that I think we should consider, because there are, we do see some surgeons, some residents who are not, maybe will not be competent upon graduation, and they still maybe should be ophthalmologists, but I think differentiating surgical versus medical ophthalmology is something potentially to consider in the future.
It's interesting you mentioned that. I actually agree with you that you got to find what makes you happy. I had one of my most watched videos so far this year on CataractCoach was a video where I just read an email that I received from an anonymous resident who said, "I'm considering giving up operating. It's just not for me. It's so stressful. I don't enjoy it." And I just sought advice from all our CataractCoach viewers, and we had, hundreds and hundreds of points of input. But I think what you're saying is actually quite true, is that not everyone has this, which brings me to my next question, though. Should we be checking for some of this? Stereopsis, I know some programs do that already. What about hand-eye coordination? If you remember back in the old days, ENT residencies used to make med students do soap carvings. Mm-hmm. So should we be checking? Like, let's say you have a surgical simulator. Should you put every med student who comes to interview on like the quick 10-minute surgical simulator just to see what they're capable of?
Yeah, that's a great question, Uday, and it's definitely tricky because we don't really want to be, for example, like the question of like disability and whether that would be discriminatory in any way is something that we have to think about. And also the other thing is it's hard to tell as a med student to predict their final sort of outcome as a surgeon, but I do feel that now, like, there was a revolution in medical retina, right? So injections are the primary treatment for diabetic retinopathy and AMD, and even neuro-ophthalmology, like many neurologists are now doing neuro-ophthalmology. So I feel like the medical aspect especially in medical retina, has been developed more. So when they get to residency, if they decide surgery is not for them, I think they should have a path to still be a board-certified ophthalmologist, but in medical. But again, that's controversial, I think.
Yeah, I mean, I guess I could see both sides of it, but I happen to agree with you. You got to find what your happiness is. Like, for me, going to the operating room is my happy place. I've said before that sometimes I'll be on vacation. Like, I was recently in Malaysia at the APO meeting with you, and I went for 2 weeks to enjoy. And when I was there, I just thought, like, oh, today's my normal surgery day. I kind of miss doing surgery. And people would think, like, what, are you crazy? You're here to enjoy a beautiful trip and this beautiful country, and you're thinking about working?
Yeah, exactly. But you're right, though. It would be really interesting to look at, are there predictors as medical students to see what their final predictors are as residents. But, we just don't have that data yet. But I think it would be interesting. But, I think if we could do it in a way that would not sort of, it would be generous, so we wouldn't be excluding people who may develop into good surgeons, which we see all the time as well. Like lots of residents start off, and then, but by the end of their residency, they really blossom and are excellent surgeons.
Yeah, the other thing too is that there are other aspects that we can do to practice and get better surgery. Now we have surgical simulators. You've got the wet lab. You've got my old-fashioned. I'm kind of an old guy. I'd always tell residents, if you really want to be great in the operating room, you got to go to the wet lab and do at least 500 sutures of 10-0 nylon. And I used to call it the Devgan 10-10-10. Can you do 10 sutures of 10-0 nylon in 10 minutes?
That's amazing.
In the lab. If you can do that, then I am sure you know how to work with your hands under the scope. And more importantly, it teaches you the drive, the hard work. So do you have any other pearls like this? So obviously you guys have a wet lab and simulators and all the above.
Yes, we were lucky that one of the chiefs who was 2 years before I was chief, Dr. Shamima Sigdar, made it her goal to develop our wet labs. So she had philanthropy, raised money for, and they opened, we call it Offset, Center for Microsurgical Training. So she really spent a lot of time and resources developing the space, and also, and we do have the IC simulator. And the other thing, we spent a lot of time on the surgical curriculum, starting for PGY2 residents. And now, eventually we hope to do it for PGY1 residents. But actually this week I got 2 emails from other PDs throughout the country asking about, how to develop that space and what the resources and so forth that went into it. So I think a lot of programs are really expanding the wet lab and realizing the importance of that. And yes, the IC is wonderful. And, we know it reduces surgical complications. So as you said, spending as much time in the wet lab with the simulator. We also have the Cataro model eyes, animal eyes, sure. Pig eyes, whatever you can do. So like you said, most people can learn the surgery with that practice. And it does, I love your 500 sutures. And actually our residents start as PGY2 or PGY3 residents. They are primary surgeons for open globe surgeries. Nice. Like you said, suturing is the basic. So, and you said you can even, now residents even have practice microscopes at home where they can practice suturing at home. And then using their left and right hands and just becoming ambidextrous, I think is important. So, fortunately most people can learn it, but there's a few who don't like it or are challenged by it, and so.
Yeah, in fact, that the non-dominant hand development is so important. When I was with teaching residents, I'd always tell them, listen, you better eat, brush your teeth, shave, whatever with your non-dominant hand.
Yeah,
and then the catch was that, like, when I take them out to the sushi dinner, I better see those chopsticks in your non-dominant hand. Let's see what you can do.
Exactly. I remember doing that when I was a resident too. So.
But no, I think it makes a big difference. You have to put a concerted effort into to really develop that. And I think, the residents to me who have stood out in the past have really just been super driven. It's not necessarily whatever natural talent you're born with. And the analogy I give is like a basketball free throw. If you told me you'd give me $1 million if I could sink 15 basketball free throws in a row, do you know how crazy I am? You know how hard I practice? Yeah. All day, every day, no matter what. So and I don't have the natural skill of someone else who's obviously much better than me at basketball, but I do it. So same with the suturing, or same with any other aspect of it. I think if they put the effort in. I had a resident once where I went very early to the county hospital. Got there before 6 a.m. I had to do a conference call with the East Coast. And I just thought I'd go. And he's already in the back room of the clinic where we have like an old 20-year-old microscope. And he's suturing a tomato. Yeah. There's a cherry tomato there, and he cut it. And he's sitting there doing 10-0 nylons.
Yeah, exactly. I think, like you said, practicing at home on tomatoes or grapes, and then also even the capsulorhexis. There's some there's some models where you can practice it on at home. I think both at practicing at home in the wet lab using simulators as much as you can during your training is essential. And you see once you get better surgically too, the numbers the residents who are better surgeons do get higher numbers just because. It's sort of like a self-fulfilling prophecy. They build their confidence, and so I think it's really important to dedicate time to that during residency.
So one of the things we're talking about is that Yeah, if the resident has picked up a little bit more agility or skill in the operating room, then that resident, he or she will be able to do more cases in a kind of a given amount of block time, and you may see disparities in total surgical volume. Are
Yeah,
you?
absolutely. I've definitely noticed that in our training. So last year, actually, I had my resident graduate with the highest reach a record at Wilmer, and he I think it was 320 cataracts, and we don't have a VA, so and he definitely really went out, really practiced every kind of surgery. I think he had the highest numbers across every kind of surgery, including secondary IOLs, corneal transplants, and so forth. And again, lots and lots of practice. So I do feel, like I said, it's a self-fulfilling prophecy, because your patients get good results and you build your confidence, and then also in systems where attendings will pass. Obviously, the attendings will pass if they feel more comfortable with the surgeon. So yeah, so it's really important to do that practice.
Are there pearls you have for the residents who are struggling a little bit or learning surgery? Because a lot of when I was in Malaysia, I was very impressed that literally hundreds of young doctors came up to me and said, in our country, and they came from various countries, there's not as much of a formalized residency training. So they're almost kind of self-taught, and they're doing these residencies that are kind of more like apprenticeships. What are the pearls you have for the young doctors who are learning surgery and struggling a little bit?
Yeah, that's the beauty. The beauty of training in the U.S. is you will get hands-on training, so there will be no apprenticeship. So I would say, as you said, practice, number one, and then also watching videos like your CataractCoach. I think there's been an explosion of resources online, and then there's also been an explosion of courses offered to residents. Like in my day, we used to all go to the Mass Eye course, so there's that still, as well as tons of other courses that they can go to. So and now the AUPO has the Standardized Surgical Curriculum Score, which is offered twice a year for residents to learn phaco, MIGS, the Yamani. So I think making the most of all the wet labs offered nationally, as well as your institution, is also critical.
I think that's great advice. Another one that I had was that don't get so hung up on the actual number of cases you're doing, but really concentrate on what are you getting out of each case? What are you learning from each case? And in particular, I used to tell residents at the end of every case, write down a couple things you did great, a couple things you wish you did better, and a couple things you're going to work on afterwards or look up, or some knowledge you don't really know, some technique. And then the other one was recording video. I think now basically all our operating rooms have the ability to have some sort of video being recorded. And residents who fail to record their videos of their cases, you're doing yourself a huge disservice, because you can't go back and watch that case. You'll never learn from game day footage.
Absolutely. I think that's a critical video review is absolutely critical. And, most of our tanks will review it with the resident at the end of the case as well. And then, as you said, the resident, I remember actually when I was a resident going to telling it like it is with Bobby Osher, and he was like, you have to record, otherwise you never know when a complication is going to happen. And then you can't sort of analyze what happened and learn from it. So in addition to recording all their cases from the beginning of residency, I think the review with experienced attending. So I mentioned Dr. Sigter, who's the head of our wet lab. She also spends time video reviewing with the residents in addition to the actual attending staffing the cases, reviewing it. So I think I totally agree with you. Their video review is absolutely critical.
Yeah, I think it's a great asset. And yeah, as you said, there's so many great online resources now that you can learn from to really advance those skills. Let's shift gears just a little bit and talk about trauma, ocular trauma. So tell us about your center. You have a beautiful center there, especially for ocular trauma. Tell us about that place.
And so we are designated, at Wilmer, we're a designated eye trauma center, which means we're designated by MIMS, the state of Maryland. So we get a lot of referrals from the surrounding region. So what does that mean to be a designated eye trauma center? We basically have specific specifications like we have to have a designated ophthalmologist in-house 24/7. We have to have the ability to see trauma patients within an hour. We have to have 24-hour capability to go to the OR. So it's great to be a trauma center, and the residents, I think it's the highlight of our program in terms of by the end of that PGY 2 year, and as PGY 3, they do a lot of the open globes, complex lid lacerations, orbital fractures. So the trauma experience is extraordinary. And I think, as I mentioned, PGY 3s begin doing open globe surgeries, staffed by an assistant chief of service. So that at Wilmer is a fellowship trained attending who is dedicated to resident teaching, who comes back and spends a year dedicated to teaching the residents trauma. So I was in that role in 2014, and that's really what started my love for trauma. And in addition to being the assistant chief of service, we call our chief the assistant director of the eye trauma center. And then now I moved into the role of the director of that. But I think the chief role helped me. A year of doing globes with the residents and constant trauma was really an amazing experience in terms of making me love working with residents, as well as starting my love for trauma.
About how many open globe injuries do you think you take care of per year?
So at Wilmer, we see, it varies from year to year, but anywhere from about 150 to 200 cases. And we used,
busy.
Yeah, it's busy. Yeah, we used to have our own IED, which was separate from the main ER. So we had a lot of volume, and a lot of people would come in with non-urgent sort of itchy burnies in the middle of the night. But now our main ER closed in, our Wilmer ED closed in 2011, and we integrated into the main ER. So overall, the volume of patients we see is less, but the acuity is pretty high because they go to the main ER, and we have again in-house ophthalmology resident on call. The attendings, the chief takes call pretty much all year, in addition to subspecialty faculty.
Wow, yeah, I think that's, I can understand for the residents, they don't want to see an itchy burny eye at 2 a.m. But a ruptured globe, they'll happily go to the OR to take care of.
Yeah, absolutely.
With such a huge volume of ruptured globe cases, which is quite large, like at our county hospital where I was teaching residents, we'd get more like 50 in a year. 50 ruptured globe cases. What are some of your just basic pros? Remember, our audience skews pretty young here. What are some of your basic pros for patients presenting with an open globe injury? Let's see, corneoscleral laceration from sharp trauma. What are your kind of basic pearls here?
Yeah, I think being systematic in the evaluation is important so that you can be thorough. But I think number one, as thinking about the prognosis, so looking for the APD, the classifying the zone of the injury, not missing an intraocular foreign body. So all of our patients get a dry CT scan on presentation. We do give IV antibiotics, one dose in the ED before they go to the OR.
Like a fluoroquinolone or something?
A fluoroquinolone in adults, and then I think the shield is important. A lot of times that's forgotten, so making sure to shield the eye. And then we usually do at Wilmer, we don't do the open globes in the middle of the night unless it's an intraocular foreign body. But we'll do it usually first thing the next morning. And so there's some debate about, basically the literature shows that if you do it within 24 hours, you're okay. But there's some debate whether there's any difference in visual outcome, whether you repair it again in the middle of the night versus first thing in the morning. Our approach is that, the OR team, even the surgeon, like we think the best, you'll be at your best kind of first thing in the morning. But again, if it's an intraocular foreign body, they will take it at 2 a.m. Obviously, other emergencies like a trapdoor fracture in a kid will also come in and do that at 2 a.m. But otherwise, it's sort of first. We have OR time that's dedicated for trauma, so it'll be sort of as early in the morning as we can get the patient there.
Yeah, one of my great pros that I learned was, when you're there to close that globe, then your primary goal is to close the globe. You can always come back and do another surgery in a few days, a few weeks, whatever it takes. But, obviously, just get the globe closed.
Yeah, that's a great point because, as we know, you can have a lot of associated injuries like traumatic cataract, vitreous hemorrhage. But I totally agree. Closing the globe is the primary objective. And, as a cataract surgeon, usually, like if there is violation of the lens capsule, I'll just try to aspirate any free lens material. But as you said, you're not really, trying to fake a fresh wound in an eye with a fresh wound. So even going back 5 days later, it'll be a much more stable situation with a better view.
Yeah, that's why I always taught the residents as well. You need to know how to set up the phaco machine. Because your scrub tech who's going to come there at midnight may not be the one who's able to set up the machine. And you have to be able to set up the phaco machine on your own if you plan to take out the lens at the same time. Like you said, a ruptured or violated lens capsule.
Yeah, so, absolutely. Fortunately, most of the the trauma patients, they're young. They have soft lenses, so you're not having to phaco hard cataracts. But yes, I think knowing how to set up the machine, the bimanual irrigation and aspiration is important.
Oh, absolutely. And then again, you were saying earlier too, being thorough, not missing anything, checking the APD, make sure you're not missing an IOFB, intraocular foreign body, checking the other eye. We see that mistake too. Only checking the trauma eye. That's obviously you got to check everything.
Yeah, we still have our residents dilate the other eye. And
We
make
do
sure.
too. You have to.
Yeah,
You gotta know everything that's going on before you get in that eye.
yeah,
So,
absolutely.
how do you talk to the patients about prognosis? That's one of the things I found the toughest was that patients were just, especially the younger ones, will just fix it and
Yeah,
not understanding. How do you talk to patients about that?
Yeah, I think the patient conversation is critical. And then Farron Kuhn in the 80s, and based on the United States Eye Injury Registry, developed the ocular trauma score, which is quite complex actually in terms of. So we're actually, in my other role as the president of American Society of Ophthalmic Trauma, we're trying to come up with an easier version that can be sort of generated without manually, sort of a electronic version. But in talking to the patients, actually, Dr. Chris Rapawana was our keynote speaker at our trauma meeting last year, and sort of, I think even though you may think the prognosis is good, I think painting a picture to the patient that's realistic, and sometimes there are unanticipated things that happen after an open globe, like infection. So painting a realistic picture, not overly optimistic, sort of like you said, talking about the other eye and the importance of protecting that and not forgetting the other eye, I think are all critical in counseling patients with open globe injuries.
Yeah, I think another thing that I was amazed by, I did some research about your assistant chief of service position, which is, I went back and looked at many decades worth. The names that are on that list are like the preeminent figures in the history of ophthalmology. It's unbelievable. If anyone wants to check this out, it's on the Wilmer website. You can find assistant chief of service. And this is basically, again, the benefit to your residents is they have this assistant chief of service who's basically on call every day for the whole year. This person has finished a full residency and finished a fellowship, and now is coming back for an extra year just to focus on this. And that is amazing to have someone with that energy and skill and obviously already trained to help you with that. UCLA doesn't have a program like that. But I think that model is really amazing. And then again, the people who have done that, wow, such huge names.
Yeah, it was a terrific experience, and I think every chief who's gone through Wilmer has uniformly thought it was an incredible year. But I think we're the only probably program in the country where you have a fellowship trained person come back and spend a year. Now some programs do have a chief year right after residency, so before they apply to fellowship, or if they're going to comprehensive, just before they go into practice. But I do think it's nice to have someone fellowship trained because you have that extra experience. So we are seeing a lot of complex cases. So having extra training is and not being straight out of residency is important. But as our trauma society is actually discussing, like, okay, at academic centers, who are the ones staffing these open globe injuries? Because like you said, it's residents repairing it, and a lot of times it may be a fellow staffing, and that could be a little bit less than ideal, especially with complex trauma. And so having experienced attendings, having people who are dedicated to not only just junior faculty or fellows, but having attendings who are really comfortable in trauma, I think is critical too. And it shouldn't be relegated to, again, the most junior, only fellows, for example.
Yeah, in fact, that's usually the case, right? And it may not even be a fellow who's well versed in ocular trauma. You were like the on the other end of the spectrum. You had like a full Moorfields ocular trauma fellowship under your belt. So you're coming back as like a preeminent world expert of the trauma. That's amazing.
Well, and they're also like, for example, the military actually has a lot of trauma courses. So like Walter Reed holds a trauma course every year, and I didn't take that before I was chief, but I think the courses, and at Academy there's a number of trauma courses that are held to go over the basics of suturing in the setting of trauma, as well as management of other ophthalmic emergencies. So I think those are great resources that those, for example, fellows who may not have a lot of trauma experience can use so that it can help them teach. Because not only do they have to, they have to teach it, which is another important skill.
Yeah, in fact, a lot of programs like here at UCLA, it was often the junior most ill-prepared person who's sometimes attending this. And these are the most complicated cases, the most difficult.
Exactly.
So
we talked about trauma fellowships in the future, and ways to encourage faculty to be interested in trauma and take call, so that again it's not relegated to just fellows.
So do you then also get cases later that refer to you, let's say, patient had trauma years ago and now has a dangling, dislocated crystalline lens for cataract surgery? Do you do a lot of those?
I do, yes. So that's another passion of mine in terms of anterior segment reconstruction after trauma. And the chiefs will often refer me, the traumatic cataract after they do the initial repair, which I'll do with the residents.
Well, that sounds like those are stressful cases, though. Those are stressful.
Yeah, absolutely. But challenging, but fun to think about. And it's nice to be in an academic center where you have the armamentarium of retina surgeons, glaucoma. So it's multidisciplinary. So I feel like at least having I'm not by myself. So again, a lot of these cases may require VR. So it's in our setting, it's quite easy to do the combined cases.
Oh yeah, for sure. Like an intraocular foreign body in the vitreous, to have your retina surgeon go back and take care of that, of course. To do
exactly,
it combined.
Or the dislocated lens where, you would want VR backup or, VR to be involved as well.
Are you mostly doing Yamane, or do you like Gore-Tex fixation of lenses? What's your typical, if your patient has no support, or honestly, even AC lenses have, in meta-analyses, have pretty good outcomes too?
The ACIOLs, yeah. I mean, it's funny. I just on Tuesday took out a ACIOL, which was stuck against the cornea, which was somebody referred to us. So I think ACIOLs are fine in the right setting. Probably not in trauma because there's usually quite a lot of damage to the anterior segment. And a badly placed ACIOL is
terrible.
It is terrible. And I will say as a cornea surgeon, I'm biased against them just because they get in the way of our endothelial keratoplasties. But yeah, so I've been doing Gore-Tex fixation with the Invista lens. So I think the Yamane is great, but I do a lot of, as a residency program director, I do a lot of teaching, and I do feel that the Yamane, there's just such, it's very hard to teach. And so I feel like with the Invista, you get more predictable results, and it's easier to teach predictable sort of refractive outcomes as well. And the position of the lens is not so subject to the
Sure.
tilt. Yeah.
Yeah, for those who may not be familiar, the Invista lens from Bausch & Lomb is an acrylic single-piece lens that has at the haplogoptic junction like a little eyelet. So it's easy enough to thread something like an 8.0 Gore-Tex through there and really get great permanent long-term fixation. Yeah, we have go ahead.
Oh, so I was going to say residents often don't realize that these were actually the Invista and then the Acryos, which is less ideal because it's a hydrophilic lens. But they were actually designed for in-the-bag fixation, but it just because of the nice design with the eyelets have been adapted for scleral fixation.
Yeah, and it works really well. We have a lot of those videos of the Gore-Tex on CataractCoach. And in fact, I've even changed my technique to something that Dr. Jamin Brown from New York described, which was the Gore-Tex is fully intrascleral. You can't see it under the conjunctiva.
Amazing.
And so that's, especially in a younger person, you're not worried about it eroding through later because the knot's in the eye, and then the pass of the Gore-Tex is actually within the sclera. So the
I have to check out that video.
Yeah, I'll send you a link. It's really neat.
That's
but
awesome.
I've also actually recently, now when I'm in private practice, actually stopped doing those cases and refer them to a former resident who's a vitreoretinal surgeon now, who just does a complete vitrectomy. I think one of the catches with Yamane is a lot of the Yamane videos that I watch done by anterior segment surgeons, sometimes you see that haptic going way back in the mid-vitreous, and you almost certainly are putting traction on the vitreous, on the macula, chronic CME. Now studies have shown that the CME rate from Yamane is much higher than expected, and I think that may be part of it.
Absolutely, and I agree with you. Whenever I'm doing scleral suture fixation, I'm doing it in a fully vitrectomized eye because at that point, like you said, you're essentially unicameral, and I think the risk of a retinal detachment is quite high. And so I've had zero retinal detachments after scleral suture fixation, and I think again it's because they're fully vitrectomized. Iris sutured, I think you can do your anterior vitrectomy, but when you're talking about a unicameral eye, you just don't want to take that chance of the patient having a detachment. And as you said, I think with any scleral suture fixation, there's high rates of CME. So I do extended steroids for all these patients. But
sure.
As you said, the CME rates are high in all of these cases.
I'll give you my other great pearl that I learned the hard way. When I refer the patient to the vitreoretinal surgeon for the full vitrectomy and then he'll suture in the IOL, I'll tell him what lens power to put to ensure that because you can't always predict the effective lens position or even a little tilt. So I'll ensure the patient ends up myopic. So maybe post-op they'll be like minus 125, minus 1 at 90. And then the patient comes back to me 3 months later, I do their LASIK or PRK, and the patients are blown away.
That's hilarious. I feel like sometimes retina surgeons ask me to do it just so you can do the IOL calculation. So that's hilarious.
Yeah, I always send the patients, and I always say, put in this power lens, and I know the patient's gonna end up just a little because obviously with LASIK, I'd much rather do a clean myopic ablation than any kind of hyperopic ablation.
Yeah, absolutely.
It's so much cleaner.
That's a great pearl.
The last thing I want to talk about is that applying to residency programs, it's just a different game now. So one of the things that surprised me is, like I said, I'm an older guy. I finished residency in 2000, and I applied to 15 programs, interviewed at 13, and got my number one. But now it's routine. I hear people saying they're applying to like 70, 80, 90, 100 programs. Is this really true? Is this where we're at?
Yeah, the average number is 70. So as you mentioned, the number of applications the number of program students are applying to have skyrocketed. So we can see this actually not only in ophthalmology, in every subspecialty. Now, many program directors, including ophthalmology, have advocated for an application cap. I don't think we're going to see it in our lifetime for reasons such as, sort of restricting applicant free choice. But I think what we did, so ophthalmology is actually the first specialty to have implemented an interview cap, which I think is great. So we're the only subspecialty in medicine to do that. And
what's
so
the cap?
actually the cap is, this year was 15. So when we first implemented it, it was higher, and I think it was 18, then it went to, and so this year it was 15. And other specialties in medicine are actually asking it, like the AAMC has contacted us because they want to know how we did it. And, I think 15 is great, because the thing about the problem with the application cap is you just don't know how competitive an applicant is. You can try to approximate and give them some guidance, but now for the interview, if they get more than 15 interviews, by definition, this is a competitive applicant. So limiting them to 15, it's hard to sort of argue that that's going to disadvantage that applicant, whereas an application cap might. So I love the 15 interview cap. I think it reduces interview hoarding, and so it benefits everyone. Because people would often accept more interviews and then cancel at the last minute, and then your other programs are scrambling to take people off their wait list, so that's not fair to the program or to the people going off the wait list. So I love the 15 interview cap. I don't think the average needed to map in ophthalmology is about 13, so it's a little more generous, but I think 15 is a nice generous cap that everyone's comfortable with.
Also, if you interview, let's say 6 or 7, you have a lower odds of matching then.
Definitely, exactly. So the number is actually 12 is the average number of interviews needed to match in ophthalmology. So again, at 15, you can be confident that your student's going to match for the most part.
Yeah, I think I got lucky. I applied to ophthalmology at the nadir, at the low point, with like the fewest number of applications. Now we're like at the zenith with the most number of applications, the most competitive ever. If I was applying to ophthalmology today, I'd be doing family practice.
Yeah.
I don't think I'd get it.
And then I think the reason we started the interview cap in the era of COVID is because in the era of virtual interviewing, you can imagine an applicant, there used to be kind of a self-cap because you can't travel to imagine arranging travel flights to more than 15 programs. Yeah. But now with the virtual, the reason SF Match decided to do that interview cap was really, they were worried that with the virtual, it would really lead to people interviewing at 30 or something programs. So that's why they instituted it. It's been successful, as we know, because they've actually decreased the cap. So that just shows it's not adversely affecting applicants. And we've done surveys, and applicants and program directors think it's a good thing.
Are we still going to stick with the virtual interviews, the online ones, or are we going to go back to in person? I kind of miss the in person ones.
Good question, Uday. So SF Match actually just shared results. So most applicants the applicants want virtual interviews, and then the program directors, the majority, want in person. So this is the thing. This is my take, and we actually just wrote an editorial for academic medicine on this. We can't go back to the all in person, because imagine the cost for applicants, right? Like these are medical students, they're living on loans, like 15 is going to cost them an enormous amount. So I do think that we have to come up with something that's more equitable. And I know, we all miss the live in-person interviews, but just the cost for students who are not, they really depend on their families, I think, to cover the cost of the interview. So the equity issue there is at the forefront. So ophthalmology was actually the first specialty again to do this the in-person open house, which about half of the programs did. So
tell me about the open house, because this is something new in the last year or two that most people don't know about.
Exactly. So this was the last 2 years that ophthalmology, and again, medicine's looking at, other specialties are looking at us as the model because they also are interested in this. So what they did was the after ophthalmology program directors submit their rank list, there's a period of approximately 2 weeks where applicants can go and visit programs in person, and that's before they submit their rank list. So
but after the program is already locked in.
That's right. So it's an advantage for the applicant, so they can come, ask any questions, feel at ease, and if they don't go, it's not going to penalize them, because that's the thing with the virtual. We can't have like an option for both in-person and virtual interviews, because if someone shows up in person, we're going to think they're just more they're more interested. So that's the whole equity issue. So I think actually for fellowship programs, they made it optional. So they said you can either do in-person or virtual, and some chose in person and some virtual, but I think it actually disadvantaged the programs that chose virtual, because other, when applicants, they would come, if when it was in person, so they would get to know more about the program. So I think whatever we do, it has to be, number one, uniform, and I think for fellowships, it should be uniform, so that you're not disadvantaging programs or applicants. And then for residencies, it will always be uniform, just because SF Match has, governs everything, and and even across medicine, like it was virtual for all medicines, all residencies outside ophthalmology. But I think uniformity is important. We have to look at equity for applicants in terms of the cost, but there has to be some in-person component. But I just think it's going to take some more. I just don't see us going back to the way it was, which was all in person, unfortunately.
Yeah, because if you think about it, to fly somewhere now, airfare's gotten so expensive.
Can you imagine with these new prices? Like it would literally be prohibitive for 15 interviews.
Yeah, it'd be like at least $1,000 per interview. That could be like $20,000 to interview at 15 programs, and the amount of just airport wear and tear. We all hate going to the airport.
Exactly. So, but the open houses, it turns out about 54% of ophthalmology programs had open houses, and about 35% of applicants attended them, and 50% of those who attended said their list was altered by the by attending. So,
in those 2 weeks, how many programs do med students go to then, or applicants go to?
So it's much less than the 15. So it's on average, I think it was about 3 to 4 at most. So much more manageable. But again, I feel there were some drawbacks to it, because, for example, so you can't really plan for it as a program, because you're not allowed to ask how many, if you're coming, until after you submit your rank list. So then some programs planned for a lot more than who ended up coming. So I think there's still some things to work out, but again, personally, I just don't see us going into the back to the all in person. So we have to continue to try to be innovative and come up with best practices for making it more fair, but also maximizing the in-person aspect for both programs and applicants.
As an applicant, how do you stand out? How do you make a great impression in a Zoom interview? I don't know what the answer is. It's...
Yeah, it's tough. Yeah, the virtual interview, I think a lot of med schools too are sort of advising students, for example, simple things like, the background, having a plain and simple background, and then practicing with them for virtual interviews, because it definitely can disadvantage, for example, I guess in-person interviews can, but for the more introverted applicants and so forth, I know a lot of program directors don't like the virtual, because it's hard to really get to get an idea of the applicant. So again, we have to sort of think about best practices for virtual interviewing, and having preparation for the students, and then for the programs. I think a lot of positive things came about it, though. So a lot of programs did update their information, their websites, things about, we've been advocating for a program, sort of transparency of programs in terms of what your program offers. So I think that improved. And so I think there were definitely a lot of positives and innovations with this that we need to keep striving to improve.
Is there any talk about increasing number of residency spots? I think U.S. is somewhere around 450, 460 or something.
Yeah, absolutely. Yeah, there has been talk about it. I know some programs, if you can, justify the surgical volume and the training, you can get a complement increase. At Wilmer, we started with 8 residents back, over 15 years ago. We had 8 residents, and now we have 5. I always tell our chair we're not going below 5, but I do think I heard so I think if you have the surgical and medical experience for the residents, then complement increase increases and increasing the number of spots that we're training, I think is good, because we see the number of applicants is increasing and the number of spots are staying the same. So our match rate is affected by that, and also the lots of disparities in ophthalmology, so geographic disparity. So in terms of most of the surgeons are located in urban areas. So I think as we think of our workforce and access, I think sort of training surgeons to be in rural areas, I think will be critical.
Yeah, I always thought like UCLA with 8 residents could definitely expand to 9 or 10, and there's certainly enough volume. LA is an unusual city because LA is such a mega city with 2 residencies, 2 med schools, compared
That's
to like
amazing.
Chicago, which is smaller than LA, has I don't know like 7, 8, 9, like a huge number. Even Boston has more than LA, and Boston's tiny.
Absolutely.
So yeah, I think there are a lot of good changes coming. Now, as an applicant, how do you stand out in your application? Because now there's no more the old stuff that programs used to do, and UCLA used to do this as well, was USMLE Step 1 cutoff level. And so now there's no more USMLE Step 1 score. There's no more grades in most med schools. And in fact, a lot of schools like UCLA, there's no more AOA. That's gone too. Alpha, Omega, Alpha. So how do you stand out?
Yeah, I think with Alpha, Omega, Alpha, they found there's some biases that they're, reevaluating how to fairly pick students to be to have equal representation in AOA. But yeah, how to stand out? That's a great question. So I think things have changed in terms of the application screening process. And as you mentioned, Uday, I mean, at Hopkins, we did have a cutoff, an informal cutoff too. So I think we realized that, the Step 1 score is not necessarily correlated with a good ophthalmology resident. But I will say, in terms of standing out, because of that pass-fail, most med schools going to pass-fail during COVID, and like you said, the lack of a score, I think a couple things became more important. So I think letters of recommendation became more important. I think the importance of mentors is critical. Many of us went into ophthalmology because of mentors and the support of their mentors. So I think you can't underestimate, finding mentors who will support you both within your institution and outside. And luckily through, many programs, like for example, the American Academy of Ophthalmology has a mentoring program, the Minority Ophthalmology Mentoring Program, and other programs. There's lots of summer programs that institutions have. So there's lots of ways to get mentors outside your institution, for example, if you're at a small institution where there's no ophthalmology department. So that's important. And then, the personal statement. So SF Match got rid of the traditional personal statement and they replaced it with questions like, name a time where you faced name a time where you demonstrated resilience, and sort of getting at sort of distance traveled questions more, and that's really important, and it really helped us. Again, the personal statement, I feel like this it's just much more focused, and it's much more helpful than just a free-for-all statement where an applicant describes why they went into ophthalmology because their family member had vision loss. So this is more again about what the applicant has overcome to get where they are. So I think that's important. Now, one caveat is what we didn't want to happen was Step 2 replace Step 1, but right. Unfortunately, I do think that's so this year. So I advise my Hopkins students, I'm like, take Step 2 if you're a good test taker, but otherwise you can wait. But then some programs they wanted to see, they were uncomfortable with no objective metrics, so they actually did want to see it. So I think we're going to have to see how that plays out. But now, I do tell the students that, do take the step, take it before your application, because I know some program directors just told me that, what's their Step 2 score? We don't, we want to see it. So.
Yeah, I think one of the most important things you said was a mentor. The role of the mentor cannot be emphasized enough. And you'll never guess, back in the mid-1990s at USC, who was my mentor? Whose lab did I work in? Peter McDonald.
Oh. That's amazing, Peter.
I was his med student, and I'm sure he thought I was dumber than a bucket of rocks, but...
No. That's amazing, yeah.
But I did,
Peter.
somehow I did, when we had these rabbits that we would do PRK on and see which drugs slowed epithelial closure, right? Because we had one of these first excimer lasers at USC. And so in the vivarium, the rabbits got Q6-hour drops. So I remember the fellow put the drops in at 12 noon and 6 p.m., and I volunteered to put the drops in at midnight and 6 a.m.
That's amazing.
But he was awesome. He had just a great sense of humor. But you're right. That mentorship made all the difference. Going to USC for med school, even though I did UCLA for residency, I came across town. They were the best people. In fact, Hopkins people, Wilmer people, who started USC's Doheny Eye Institute at the time.
Yeah.
The chairman at the time was Stephen Ryan. The vice chair was Smith, Ron Smith. Amazing people. And John Irvine was my mentor too. And
yeah,
these are
we used to call it Wilbur West, actually. So when I was a med student, USC was something where a program we all applied to, and and many of us went to. So yeah.
Yeah, it's changed a bit over the years. All these programs have obviously keep evolving, keep changing. But yeah, getting that mentor, I think, is so important. I recently was talking with a couple of med students. Multiple med students actually emailed me through CataractCoach after the match because they didn't match at all. And they were just wanted to seek my advice. And I talked to all of them. I talked to all of them to see what advice I could possibly give them. But sometimes it's hard to stand out in the letters of rec because, you and I have read thousands of applications. That's not an understatement, thousands, certainly over the many years. And all the letters tend to sound pretty similar after a while. No one submits a letter that's not amazing. So The only thing I could think of to stand out was I told these young applicants, you got to find someone who's going to go to bat for you.
Yep. I think that's critical. Good mentorship. First of all, they advise you kind of. So at Hopkins, we tell the med students meet with myself and our med student educator, who's Dr. Henry Jampel, kind of before, during, after. So in addition to their mentors, and like you said, the mentor is just critical at every step from the decision to apply to ophthalmology to whether they pursue a fellowship to even faculty. Like you said, mentorship is key.
So how on your end, because I still remember going through applications, even as late as last year or the year before, where you were given hundreds of applications to read. And the amount of time it takes, and I'm so concerned with giving everyone a fair shake that I spent time reading every single application, every answer, every letter. But after a while, boy, I had just dozens of pages of notes. I looked like a mad professor. Mm-hmm. How do you make sense of it all when you get your program? I'm sure Wilmer got more than 500 applications.
Yes, well, we had 470 this year.
Okay,
but yes,
pretty close.
It's steadily increased each year. But yeah, I'll tell you, this is my least favorite part about being PD, the selection process. But one thing we did over the last few years is, number one, like you said, we got rid of the cutoff of, and then the USMLE cutoff and sort of these, arbitrary metrics. So we do review pretty much all applications. So we had to expand the committee. The other thing we do is we have each application reviewed by 2 different faculty. So I know it's more work, but you can imagine one faculty member, let's say you're tired and you're just going through it quickly, sure. And then so now that each one gets 2 reviews, and then I could be the final judge. So for example, if 2 faculty say yes, I don't have to spend that much time reviewing the application. But if one says yes and one says no, then I'll spend some time. So I think the whole, and actually the AUPO had a whole session on holistic screening and different rubrics that you can use to make the process more fair, because unfortunately there's just a lot of biases that.
What are some of the rubrics, or what are some of the ways of doing it, just kind of in general?
Right. So, just going beyond the, so they have experience, attributes, and metrics models. So again, going past what we used to do, which is AOA, yes, no, sure. USMLE step 1 score, and sort of looking at, the distance traveled. There's, actually some programs have a distance traveled score now.
Distance traveled mean your experience in life, what's your life path?
Exactly. Gotcha. What you had to do to get to where you are, because, some people had, to face a number of barriers to get where they are. So looking at that and crediting the applicant with the background, first generation college graduates, for example, or having to support yourself working through college or medical school. I think that's all very important. One thing we're seeing, Uday, when we look at AAMC data is that medicine is becoming a more elite subspecialty. So we have actually made strides with women. Now there's more women in medical school. Racial and ethnic diversity is better, but the socioeconomic diversity is actually worse. So more and more,
wow.
They're coming from the top, quintiles of, they're basically coming from families with the top 2 quintiles of income. So and you can see it's getting worse over the years. So I really think we have to pay attention to some of the metrics, again, first generation college graduates who may not have all the resources that someone whose both parents are physicians have, and so forth. So looking at that and, other things like service, leadership, and just giving value to other less traditionally valued, resilience, for example, I think is important. And also ophthalmology, we were I think the only specialty to uniformly use situational judgment testing.
I don't know about that. Tell me.
Yeah, so basically, this is something that's been used in undergraduate medical education, where students are given different scenarios, and they have to answer how they would respond. And there's also some recorded recorded questions that we can actually see the student answering questions. We use the company. It's Alta Suite or Casper. So again, it was new for us as program directors, and I didn't have any experience with it before. In terms of some of the students had actually used it when they applied to medical school, the situational judgment testing. But it's just another sort of less, it's another metric that sort of assesses how students respond in sort of stressful situations and teamwork and things like that. So they ask different questions. So that we use that, and actually AUPO is analyzing, how that affected our screening process. But just thinking about more ways that we can use holistic screening, but to improve our selection process, which is very imperfect and biased, and we all know that, and random.
Yeah, so I actually just wrote that down. Hold on, I'm going to look this up. Situational judgment
testing.
Casper,
exactly.
Huh? I'll look it up.
Yep, exactly.
I'm like a blank slate here. I don't know anything about it.
Yeah.
But it's interesting. Yeah, because it begs the question when you say it's that slanted. So it just kind of almost doesn't give hope to people who are a different part of the economic spectrum of even ever being a physician.
Yeah, absolutely. So, a lot of our programs, like our diversity programs, we've expanded to include, for example, first generation, college graduate, and or socioeconomically disadvantaged, which I think is important for DEI programs to include as well.
Yeah, wow, that's all great advice. So we'll see what happens with the next match. But I also think that there's a reason why they don't want to limit the number of applications. The SF match people are getting paid per application. And it ain't it's not that much more work. They're getting a lot. In fact, I think there are only two specialties left in SF match, right? Urology and ophthalmology, only two.
That's right. Actually, yeah, we just had a publication on like the lack of the couples match because there's a lot of more and more medical students are also becoming couples. So it's a disadvantage that we're not sort of able to offer them a couples match. So yes, you're right. There are only two specialties left. I do think one other innovation we didn't discuss today, which I think is important that we're seeing in ENT and many I think 17 other specialties is signaling, preference signaling. Have you heard of that?
Oh, I'm writing this down too. Tell me again.
So this is signaling. Yeah. So this is something I know many ophthalmology programs are interested in. So basically, the students get a certain number of tokens or signals where they can express their interest in a program. So right now, there's all these backdoor conversations, like, you'll get emails from chairs, other program directors about a student's interest, the student themselves about their interest in a program, which is, there's a little bit of unfairness to it, right? Because some students may have, but now with preference signaling, for example, the number of signals varies per specialty. But for example, in ENT, they may have the ability to give 5 signals to their programs they're interested in. So that, for example, since we don't have a couples match, that could be very helpful. And there's been positive sort of feedback from both programs and applicants on preference signaling. So we may see that in ophthalmology in the future. But I think it's a way to sort of limit, like you said, to deal with this application, the application inflation problem. But in a sort of systematic, fair way. And what's the optimal number of signals? We don't know. And I think we should be generous with the signals so that, the students, but I do think it's nice to have, that's, again, a more uniform way of signaling interest that's more fair than all these kind of backdoor conversations that currently happen. And it could help applicants with like geographic constrictions, like a significant other, which they, can't couples match with. And now it's 4 years where they'll be separated. So it's really important.
Yeah, that's so interesting, too, because the way the match process works, ideally, the applicant ranks the programs that she or he likes best in order. The programs rank the applicants that they like best in the order. And it shouldn't matter, does the resident want to come, does the applicant want to come to our residency program? The programs are so concerned with, like, we don't want to go too far down our rank list. Why?
Yeah.
I don't get it.
I know. Like you said, no one, it's more like a pride thing, right? I think it's like an ego thing that, you matched in your top, like you said, it shouldn't matter. And I think many program directors do try to not consider what you said. We try to say that, look, we're not going to try to figure out if they're going to come here. We're going to rank them based on,
Right.
qualifications and nothing else. But but the signaling, again, at least it can, in terms of reviewing 470 applications, it can maybe help if, let's say, you come down to two and they look equal on paper, but then you have a signal for one. It may help, and then again, a fair way for applicants to sort of express interest in a program.
Would that be you'd be able to use your signal token before the interview or is after the interview?
Yeah, no, it's to get the interview. It's before.
Oh, fantastic.
Mm-hmm. Yeah.
Oh, that's fantastic.
But you're right. You're right, though. Signal. They did think about signals at different stages, but the way ENT and them used it now was for the initial interview. So that's, again, dealing with this whole, dealing with the unprecedented number of applications. So this will help program directors.
Kind of narrowed that down. Yeah, there's also a geographic bias. So I talked to a med student who was from New York general area, tri-state area, went to undergrad there, med school there, everything there. And he says he only got interviews at programs in New York and New Jersey. He got no interviews at programs in any other state. And he says he's willing to travel anywhere.
Mm-hmm. Exactly. This is what the preference signal would help. And imagine, like, if he asked his mentor to email every single program and everyone did that, right? We would be inundated.
Yeah.
So this is why I think the preference signaling is a nice, neat way to, everyone gets the same number of signals and, but I just think it has to be generous enough so that, students don't, spend a lot of time worrying about, so it could be like 10 signals, for example, which would not be 10 out of their 70,
Yeah, that's not bad. Yeah, I think that, well, because you said that the number of programs you need to interview at is kind of a dozen-ish.
Yeah.
So you want to make sure at least some of those dozen are like in the geographic areas or the programs you like, or like you're going to couples match or.
Exactly. Yeah, no, and it does take counseling because you don't want them to signal only top programs because, like you said, the student would shoot themselves in their foot. So you want to have them signal sort of a wide variety of tiers, like top tier, middle tier, and so forth.
There's one more secret too for ophthalmology residency that people may not know, that it's the horse, not the track, that wins the race, and a good horse can race on any track. And as much as I loved my UCLA residency program, which is where I went, it actually doesn't matter where you do residency. It just doesn't. It just really doesn't.
That's a great point, Uday.
Right? So it's what you get out of it. Anyway, I want to thank you. What an incredible interview. I really enjoyed talking to you. I learned so much about residency programs, this whole application process, which is new to so many people. And we have a lot of med students who listen to this podcast. You'll be surprised. And then my favorite of all is the ocular trauma. And if your residents have good video of ocular trauma cases, please send them over for CataractCoach. I'll edit them even. I'll do the voiceover. But we're always looking for good video.
That sounds great, Uday. You've really touched a lot of med students and residents through your podcast and your CataractCoach. And, thank you so much for sharing your expertise. And it's been a pleasure.
All right. Take care.
Good night.
Thanks for enjoying that podcast with me. I trust that you learned a lot about ophthalmology residency and even how to deal with certain types of ocular trauma. Next time, we're going to have another great podcast coming up with a mentor of mine who's going to give us some very valuable lessons that I guarantee you will shape the future of your career. These are pearls that I learned from him many years ago and have turned out to be incredible. Remember, too, our podcasts are available on Apple, Spotify, Amazon, Google, wherever you find your podcasts. You can download them so you can listen as you exercise or drive to work. I think you'll enjoy it that way as well. And remember, starting next month in June, we're going to do a new podcast every single week. It's going to be some great learning. Stay tuned.